Welcome to another session of EMSconnect. Now, for those of you joining us for the first time, this is interactive, so while we won't have any live questions to pop up answers on and submit, we'll still be offering a gift card. But this is a different session where we weren't going to pick your brain too much on this. It's a little bit more serious than our typical conversations, okay? So it's not going to be a lot of frivolous, fun stuff this time. We're going to be going through some hard truths, and I hope everybody's going to keep an open mind and open up their ears on this one. If you have any questions or comments, you can type them into the question area in your control panel and just hit submit. We will be offering a prize like usual. We're just going to do a random drawing for a $50 Amazon gift card to any of the live participants. Even if you're not a member of EMSconnect, you can win this. If you are not a member, we highly encourage you to become one. If you work for an agency, which most of you do, I recommend you talk with your agency manager and have them look into EMSconnect to handle your continuing education for your crew. It's only $5 a person each month, and we take care of a lot of the problems that are out there in maintaining your certification. This is provider mental health, so this is not about patients. This is about you and preventing you from becoming a patient. I'm your host, Dr. Dierks. I'm an emergency physician, EMS medical advisor locally where I live. I'm the EMSconnect program coordinator, and I'm in Spokane, Washington. I am very lucky to be joined by one Miss Farina. Anne is pretty a spectacular individual. So I met Anne as she works in my area. She was a medic at the time, and not only is she a medic, she started, along with some other people, Code Green campaign, and now is currently in school for psychology and nonprofit management. She's the executive director of the Code Green campaign, and we'll explain that as we go. And her location is here in Spokane. She is joining us at this time. Also, she is going to be the speaker for those of you in the Northwest area of the United States. If you're going to the Inland Northwest Trauma Conference, which I believe is in Coeur d'Alene, Idaho, in April, she is a presenter there, so bravo to Anne. And if anybody was wondering if you've ever seen this beautiful artwork, there's lots of EMS artwork like this. If you ever wondered about this piece of art, that is Anne with her back to you. That is Miss Anne Farina right there. Pretty cool, Anne. I'm impressed that you're in artwork. I mean, you're kind of a high-profile individual at this point.
Yes, I am. As much as I try and as much as I try and hide it, I'm still waiting for the day that I get recognized in an airport
There
or
you go.
something
Well,
equally embarrassing.
if you're going to keep your back turned, it's going to be hard to be recognized. But
There was a method to the madness that was absolutely deliberate.
that's well done. I would have done the same thing. All right, so as we go through this, this is basically the topics we're going to hit on. So we're going to talk about what is it to be an EMS provider, okay? And that's something you guys know better than I do, and Ann knows especially well. We're going to go through some of the scary facts that are out there, talk about burnout and coping with stress, and that's something I know just as well as you. And then we'll talk about your mental health and some resources that are out there if you are having any trouble. Being an EMS provider, what we want to do here is give you a spoiler alert, what this is going to be and not going to be. First and foremost, we recognize that what you do, you're going to be exposed to traumatic events, okay? That's expected doing what you do as a first responder. You guys are exposed more than I am. I might be in the ER and seeing sick people, dying people, watch people die, code people. Yeah, I recognize that. But what you guys do is far more difficult than what I do in the ER. You have to be the first people on scene when things are chaotic and out of control, or responding to that house where it's hoarders and there's just disgusting garbage everywhere and feces and vomit and blood and the crime scene and death. You guys are responding to things that I can't imagine, and I'm in the ER. And so my hat is off to you. You guys are far stronger than we are. But the problem with what you do is that your risk of developing things like PTSD and major depression and panic disorder, generalized anxiety disorder, social anxiety disorder, and the vulnerability then you face for a potential substance abuse disorder is higher than mine. So this is something that we need to talk about. Okay, we need to get it out there. So disclaimer right off the bat. I'm gonna hit home here, okay? I might tick off some of you guys, especially some of you older dudes, or maybe even chiefs or EMS officers out there. You need to open your ears right now, okay? If you think this doesn't apply to you or your crew, you are wrong. And we got the data to support it. If you think this only applies to young people, new providers who just don't have experience yet, okay, haven't spent time in the trenches, you're wrong. If you think this is a bunch of malarkey, you're actually part of the problem, okay? So you need to probably keep your mouth shut at that point and open up your ears. So this stuff applies to everybody in this profession, new, old, experienced, inexperienced, okay? And we have the data to prove it. So let's talk about your bucket. Everybody's got a bucket, okay? And your bucket is how much can you hold right now? And your bucket is not a static thing. It's dynamic. It changes, okay? For example, your bucket today, let's say you had good sleep, life is great, you're financially well off, you're doing okay, your retirement's secure, you're an older provider, and you're like, I got my stuff together, baby. I'm doing all right. I can handle trauma, I can handle codes, I can teach young people. Man, your bucket's big and it's hard to fill. So what happens tomorrow if you get word that your wife has got terminal cancer, she's going to be dead in 6 months, or your kid is dying, or worse yet, you get a phone call your kid died in a car crash. Your bucket on your next shift is entirely different, and your responses to stress entirely different. Your potential for developing one of those problems I talked about, very high. So don't look at this like this can't happen to me, because the data's out there to prove it'll happen to anybody. So what's the lure of EMS? Anne, what was your lure? Why did you go into this in the first place?
So of course you had to ask me that.
Yeah, of course.
I was 17 years old, second generation, and I was short a number of college credits, and the EMT class was the exact right number of college credits.
Well said. Well, that's what a lot of them do, and I think it comes up here in a little bit. A lot of younger people look at it as it's shorter than 4 years of college. It's easier. I can get out there, make an income, and like, hey, look at the lure of this stuff. Like, I can help people. I can save lives. I get to drive fast, right? Lights and sirens. People move for you. You get to have controlled chaos. There's police and helicopters and trauma. I mean, they make TV shows about this stuff, right? And so of course
Yeah.
there's a lure. Of course people want to go into this stuff, but they're kind of blindsided, I suppose, once you get into it. I mean, really, how fast were you exposed and you realized, oh my gosh, this is different than I expected?
I was second generation. My dad was the fire chief in the town where I grew up, so I had a little bit of exposure
Hmm.
and knew a little bit that it was what I was getting into. But yeah, I was disabused of my the lights and the glitz very quickly.
Sure. So you had a pretty good
From
idea before you started.
Yeah, but it was I mean, from where I went to school and where I started compared to the next job I worked was drastically different.
Really?
Yeah, so rural Alaska versus an urban area, you get rural Alaska where it's like chainsaw accidents and snow machine accidents
Hmm.
and things like that. And you don't have necessarily all the social as much of the social services stuff. You have some, but there's a much different dynamic, and so there was two very different realities, and so the reality of the job is very different, and that's one of the things that we're not well prepared for. And then you can switch jobs, or even just switch agencies, and the reality of the job can change quite a bit.
Yeah, and I suppose, I mean, even being 17, I mean, at least you had a dad who was in it, but I can't imagine a 17, 18-year-old, 19-year-old even, I mean, geez, anybody in their younger 20s, unless you've been exposed to this in an ER or somewhere from family, I can't imagine being in my early 20s or in my teens for that matter, and going on my first multi-system trauma, death on scene, SIDS baby. Oh my gosh, like I can't even fathom that or how you'd process that unless you had some exposure. I mean, you see here kind of the reality of what EMS is. I don't want to turn people off. If we have listeners that are like, I'm kind of thinking about going into EMS, but after they watch this, there's no way in hell they're going to. I don't want to turn people off too much, but here's the reality of what EMS is, okay? Like me, you work nights and weekends. It's 24/7 job. The salary is not the best in the world. It's potentially dangerous. You are going to be in scenes where chaos is happening. You're really not going to get a lot of thanks from a lot of people. I mean, it's going to be there, but a lot of people you transport aren't going to thank you. They may even be hostile to you. You're going to second guess yourself a lot, and that's something I know well after 10 years of working in an ER now since residency. Is you always remember those cases where you think, did I screw up? That patient died. Could I have done something different? Should I have rechecked this? Should I have given this? Should I have done this procedure? And you remember those far more than you remember the cases where people thanked you or hugged you or said, anything positive. You remember all the negatives, which is sad, but it's true. And those things can really start to weigh very heavy on you after a while. And a lot of EMS providers work multiple jobs, whether it's for multiple agencies or work other jobs on the side, just to make extra income. So between working nights and weekends and then extra jobs, that's pretty darn stressful. And so the stigma is out there, and the stigma comes from kind of years of a male-dominated workforce and environment. And so this isn't something I know well. I mean, I work with EMS agencies, I work with fire departments, but this is not something I was really exposed to. And you were probably exposed to this far more than I know.
As far as the male dominated
Yeah,
workforce, yeah, in paid fire departments, it's about 92% male dominated. Volunteer fire departments, it's about 70-30, and then EMS, it's all over the board.
sure.
60-40 is a commonly cited number, but it varies a lot depending on what part of the country you're in. So it's, it kind of runs the gamut, but it's, overall anywhere from, like I said, 92% to 60-40. So.
And common sense would only dictate that you take a young population that's mostly male. Your exposure to substance abuse like alcohol, binge drinking on the weekends or after shift, it's pretty likely to happen, and that's just going to lead to other problems. Now, the skewed perception is, this is what we see on TV and in the magazines, and this is what we expect from the job. I mean, look at that young lady on the left. She's so young and healthy and happy and smiling and so appreciative. And on the right, you got your helicopter cool stuff. But the reality is, you're working in a cramped environment. These guys are trying to resuscitate a cardiac arrest. I mean, this is a young patient. Who knows if it's a gunshot wound or what? I see some blood on the belly. This environment's not very conducive to feeling like you're in a good situation. It's going to be hot, cramped, sweating, and you got 4 people crammed in the back of an ambulance trying to keep the public eye out of there. You've got scenes where people have blown their heads off, put bullets through their heads. I mean, most of the bullet wounds I've seen, they're not older people. These are young guys. These are young girls. Like most of the bullet wounds I've seen in the head are teenage to 20-year-old males. And these are people that hit home, and you remember these cases. You see the hangings. You have the EMS, the ambulance that's just got blood and puke all over that you've got to clean up afterwards. I mean, people don't think about this stuff. You have scenes you're responding to where you have to go into this environment and pull people off the floor, or worse yet, code people on that floor by the cat litter box where there's feces everywhere. The place is horrible, and you have to like kneel down, lay down in there, intubate. And I mean, that alone would cause PTSD, okay? You've got the hoarders where you're trying to treat diabetic emergencies in this place and you don't even know where to sit. Then you sit down and you realize you sat on a cat. And so, I mean, this just gets worse and worse. You show up and I mean, this is a patient. How do you transport this patient? How do you even start to comprehend getting the patient out of the house? This is stuff people don't think about, and it starts to drive you a little crazy and really stress you out. And then you start having abusive people who come at you and try to hit you, and a lot of people have been hit, okay? You got to protect yourself. And then, obviously you got drugs and alcohol and people being belligerent, and you're trying to restrain people, and you all of a sudden in your head you're realizing, I wanted to help people, and now I'm holding people down and trying not to break arms and legs or dislocate things while I'm restraining them. And that makes you feel pretty awkward. It always makes me feel awkward if I have to help restrain somebody, and I try to always help because then I can watch everybody and make sure they're being safe and kind to the patient in the most possible way.
Well, now in modern times too, everybody's concerned about being like the next person that ends up on YouTube or Facebook or Twitter and everything too.
Yeah, I can't imagine responding. I mean, everybody's phones are going now. And then obviously you have the homeless population that is really overutilizing the emergency department and ambulance services for transport. And some of this stuff starts to wear on people. And I've seen a lot of providers, especially as they've had quite a few years of experience, start to get kind of cold and lost their compassion for a lot of these type of people because they just feel like so much of these cases are abused. They're abusing 911, they're abusing the ambulance service, they don't have an emergency, that when they actually do respond to a case where maybe there's altered mental status, they just assume it's alcohol and they're missing an actual medical emergency. And I can be honest, I'm in the same category. After 10 years of practice, I really have to check myself once in a while that I'm not getting too jaded. And it definitely happens, especially on a night shift. And then you start getting into the stuff that burns you for life, and you can't forget it, and you lose sleep and you have nightmares about. You see kids that are abused, beaten, and you just wonder how somebody could actually have it in them to do that. That's the things that used to bother me the most. Luckily, I don't do peds anymore, thank heaven. But when I did do peds in my previous work, I had a hard time. I was having some major burnout after a few cases where you're holding the little kid and he's got sandal marks on his face, pattern bruising from his mom beating him with her shoes. He's just crying and he's just clutching to me and he's peeing his pants because he's so scared. And you realize that, while there's nothing medically to do for this young kid, you have no control over where he's going. And the courts might send him back with the mom, and you just want to kill the mom then. And that's the stuff that burned me out pretty bad. I handled the trauma and stuff pretty well, but it got to be the kids. Watching kids die, having to tell families their kid died, that really got to me. I had a major burnout factor quite a few years ago when I had to go through this stuff. It's never easy to tell a family somebody died, but especially hard when it's a little kid. That hurt me bad. And then obviously telling the family, that's horrible because there's no right way or perfect way to tell a certain family all the time. Every family's different. Some families want a lot of explanation. Some families just want it out there and in the open. And you never know what the right way is to do. But generally, I would recommend going the shorter route. Don't beat around the bush. Tell them their loved one has died. Ask them if there's any questions you can try to answer, but you don't have a lot of answers right now. And then just be there to try to answer any questions they might throw at you. So I had to throw this in. This talk has a lot of research behind it. Okay, this isn't just me or Anne coming at you. This is a lot of research. And so I had to put this in there, 5 reasons you should not be an EMT. Number 1, you think you'll look good in the uniform. 2, you met an EMT at a party and he had the best stories. That's kind of a classic one because people like to hear stories from me when I go to parties about ER cases and crazy stuff. And you got to be careful about what you talk about. But it can make you feel a little inflated. It makes you feel like, oh, you do kind of something cool. They make TV shows about it. And it can definitely be a little bit of a lure. But be careful because those cool cases or funny stories are like once or twice a year. I mean, they're so rare. You want to drive fast? All right, there's many articles out there of people falling asleep at the wheel or getting in crashes in ambulances that will take that cool thing right out of the picture for you.
Yeah, I've got bad news for people. Lights and sirens are going the way of the dinosaur. Like before I retire, lights and sirens are going to have
Yeah, and don't you think that
been eliminated?
most of your shift is non-emergent transports at this point, right?
Yeah. For the most part, they're going away. It's one of those things that's being talked about in kind of the upper echelon circles. They're being phased out more and more and more. So
ooh, if you have stock in the lights and siren companies, ooh, time to sell.
right, yeah.
I'm not giving any financial advice. Disclaimer. There you go. And we've already mentioned it. Okay, 16 weeks of school is shorter than 4 years of college. Okay, and that you want to save lives. Yes, you will have people that you resuscitate and you get a heartbeat back. That happens once in a while. The vast majority of your cases, though, I mean the vast majority, you're not saving anything. You're finding a high blood pressure. You're seeing a blood sugar that needs to be corrected. You're transporting somebody for their chronic back pain and they want a refill of their narcotic. That's your bread and butter case, okay? These are bread and butter cases. So don't feel like you're going to go into this and every day is going to be life-saving case after case after case. And so the reality of the job is that it's not about being something, it's about doing something. And this is right out of that article, okay? The majority of the job is mundane and routine. Don't feel like you're going to be the star of the party all the time. And like Anne mentioned, lights and sirens are probably going the way of the dinosaur because there are many cases now of ambulance crashes, whether it's because of driving fast and you hit somebody, somebody hits you, or people are falling asleep at the wheel from EMS fatigue.
It occurs to me that I think I was in an ambulance crash before I actually resuscitated somebody successfully.
Classic. There you go. Life of an EMS provider.
Right, yeah.
Yeah. And the 16 weeks of school. I used to work with a paramedic education program as a medical director, and I can tell you, it's no cakewalk. I mean, we demand that you know physiology, some chemistry, a lot of pharmacology. I mean, it's intense training, and talk about short. I mean, this is stuff that most people learn over a year, and you're doing it in 16 weeks. That's not easy. It's not easy at all. And then obviously you want to save lives. And there's awesome, awesome cartoons. You see them in Gems all the time from Paul Coombs, and pretty funny stuff. And that's a classic kind of situation. I mean, this old lady wants a transport because it's brisket on Tuesdays in the hospital. Most of your calls aren't life-threatening. Many aren't even time critical. So let's actually hit some scary facts, okay? And Anne, definitely, this is your stuff. Code Green campaign, and kind of explain, please, what Code Green campaign does and where the stats come from.
Yeah, so one of the things that Code Green does, we're a nonprofit organization. We have a few different programs that we run, and one of the programs that we engage in is we help track first responder suicides. They are not tracked by the federal government like the line of duty deaths are. And so we help another nonprofit called the Firefighter Behavioral Health Alliance track those. We both collect suicide data, and then FBHA does validations and acts as kind of the official reporting agency. So we feed all our data to them. So right now it's estimated that we are collecting about 35% of the true total of first responder suicides. This is the most current data as of yesterday for validated suicides. The jump you see there between 2013 and 2014 is strictly due to increased reporting. Code Green was founded exactly 4 years ago now. Our 4-year anniversary is March 16th. So and so that we were founded in March 16th of 2014. So that jump you see is just increased reporting. FBHA and Code Green have slightly different audiences. So the variation you see too is a little bit because of differences in the amount of classes we teach. We tend to get a lot of our reports when we're out teaching classes, and so FBHA had a grant where they were out teaching a lot of classes in 2015 and 2016, and then that grant expired, so they weren't teaching as much. But with this being, if we assume that that 145, that 143, 141 number for 2015, 2016 is 1/3 of the true total, we're looking at, a first responder suicide. This is just fire EMS. We're looking at, a first responder at a minimum of every single day of the year. So adding in police, we're basically doubling the numbers. So it's a significant number of people. Best kind of educated guesstimates are that the suicide rate is at least 2.5 times higher than the general population, probably closer to 3 or 4 times higher once we get down to if we can actually get truly accurate reporting. There's a couple people trying to get more accurate data. We've got a colleague in Minnesota who is cross-referencing every EMT license with every death certificate in this state for the last 10 years, trying to get an accurate idea for that state. A group in Arizona just pulled all the death certificates for the last several years in Arizona. It looked at the job line, the profession line on their death certificates, and they got a increased suicide rate there. The issue is that for volunteers, that doesn't show up. So, if you're a volunteer EMT, but your day job is a welder, well, welding is what goes on your death certificate. So even their numbers aren't actually the true total of fire EMS suicides for that state. So it's still an underreporting, even when you go off the death certificates like that, which is why Chris's numbers in Minnesota will be more accurate with him cross-referencing those. But he's not done yet because he has to do it manually.
Ooh, that's a lot of time. So obviously this stuff has become much more mainstream in the media, and GEMS has been hitting on it pretty hard, and it's just showing up more and more and more, thankfully due to organizations like the Code Green campaign, and so it's being picked up, and now things are starting to be studied. So GEMS back in October 2015, what they did was they had a survey that was to look at critical stress in EMS providers only. And it was sent to all 50 states. They utilized social media and spread this thing out as far as they could go. They hoped for 500 EMS responders to respond. What they got was 4,000, over 4,000. And what they were doing was they were asking people if they ever thought of or they're really polling providers who thought of or completed suicide. And they found out then, obviously you completed suicide, you can't respond. But what they did was they found out the correlation with EMS and this critical stress. And they defined critical stress as stress resulting from a single critical incident that had a significant impact on you, or the accumulation of stress over time. Okay, so both the accumulation or that one event.
Really quick, one of the important things about the way that they did this is the fact that they allowed the respondents to it was based on their own definition of critical stress and not what somebody else defined as critical stress, because too often it's what a manager or bean counter defines as critical incidents, and what is a critical incident for one person may not be for somebody else. And so that was kind of a really important part of how they worded that.
That's interesting, because then 86 people saying the stress they had was critical, and that's obviously a lot.
Yes.
That's a ridiculous amount. And then, the scary thing, 37% had contemplated suicide. And then the fact that over 6% attempted suicide, that's almost 1 in 10. That's a lot higher than the general population, and their data then supported that. And so then what they looked at was they compared suicide contemplation and attempt rates between EMS providers and the general public. And so EMS is blue, general public is orange. Pretty obvious and alarming differences. And if you want to clarify it even more, it's 10 times the national average on suicide contemplation. On the suicide attempt, it's 13 times the national average. And this is data from 2015. That's alarming. That's bad. And then you talk about, they looked at the effectiveness of formal support institutions, so like the critical incident stress management, and the EAP is Employee Assistance Program. And so in the EMS world, I know this from talking to EMS providers, that like in the fire and EMS, if there's a big critical incident or a bad case and somebody dies, people kind of poo-poo these. People really shun them historically. It's kind of that whole bravado of fire and EMS of, we don't need this stuff, or it doesn't work. And in this study, they actually acknowledged that they thought, their hypothesis was that these two entities are really not going to be that helpful in the long run. And they were proven wrong. What they found out was that for the critical incident stress management, 81% of respondents said that it was in some way helpful, from somewhat helpful to extremely helpful, okay? And of the employee assistance program, it was 70% of people thought it was helpful. So for all of you guys out there who think that this is all crap, that you don't need this stuff after a bad incident or a bad event, or that your crew doesn't need these people to come in and help out, please, please don't be ignorant. This stuff is good. Utilize it, okay? This will help protect people from having long-term problems and figure out ways to get around the stress or to deal with the stress. And when they looked at the survey responses, like the actual free typing in about people seeking support and why they didn't or why they did, I mean, look at these comments. The fear of being fired. Okay, we're not allowed critical incident stress management at our service. So that's in regards to, why they wouldn't ask for it, because it's not even allowed there. The second one, I asked for help and ended up losing my 22-year career. I mean, why do you think people don't then acknowledge they're stressed or suicidal or getting more depressed or needing medications or asking for help? If people are afraid of losing their job for asking for help, of course they're not going to, and it's not going to get any better at that point. And so this is a cultural problem, and it's now coming to a head, and it's now in the light. People are researching it and studying it. People like Anne are out there trying to make people aware and get the data out to everybody. But we need to stop being ignorant and recognize it's a problem and not make it so complicated or hard for people. I'm like getting all ticked off. I need to probably get off my soapbox for a little bit, but I'll calm down. I'll take a sip of tea and I'll be calm. All right. So then they also found out the alarming rates of EMS provider stress and thoughts of suicide. And 40% of the people who did this survey had access to support but didn't seek it. And then a fourth of those were concerned about how they'd be viewed at work. And that's common sense. That makes sense. That's just people don't want other people to think they're weak or tease them or bully them. I mean, this is the kind of stuff kids go through in middle school. And I'm sure, Anne, I'm sure you've seen this before, given your experience. It's just out there. It's pervasive. It's everywhere.
Yeah, I was going to say, you sound perfectly calm by my standard right now.
Really? Oh, man.
Yeah.
I'm all fired up, Anne. So let's then look at what's out there for support. So what they then looked at was how many people contemplated suicide or attempted suicide and responded to this. And then if they had support available at their agency, did it decrease the rate of contemplation or attempt? And what they found out was the more support that's available locally at the facility or available in the community, the less chance of them contemplating or attempting suicide. So it just goes to show you that the more support you have, the less likely you are to have any problems after. I mean, this is like common sense. And so the fact that people didn't think it was a problem or thought this stuff was malarkey is just kind of goes against all common sense, which is fascinating to me. And then this is basically a graph showing for providers who sought help for stress. So people are stressed out and they asked, did you seek help? The ones that responded 52%, the bigger bar there, were the ones that had full support and encouragement locally in their agency. So if your agency has that support or locally you have that support available to you and you know that, you're more likely to seek it out, which is positive. It means people otherwise wouldn't have even sought help. So in summary, what they basically found out was that suicide contemplation and attempt rates among EMS were significantly higher, 10 times higher, than the general population. And it was multifactorial. And so they acknowledged that poor sleep, feeling underappreciated at their job, poor overall health from the decreased sleep or the exposure to fast food when you're on shift and gaining weight or being obese or having other heart problems or just general health problems to begin with outside of the job, just caused more stress on you. In general, and this is from them, this is not from me, this is straight out of the article, it's why we quoted it, you need to decide to be part of the solution and not tolerate the behavior of those who are part of the problem. Support those who promote a positive culture. And so what they're not saying here is if you are being negative, you need to shut up. Okay, so that's my nice way of saying it. So
I know these guys, and that's basically what Monique would tell you too. If you're going to say something that's going to add to the stigma, just stop talking.
Well, it just goes back to the general mantra. If you don't have anything good to say, don't talk.
Right. Yeah, exactly. don't add to the stigma. You can absolutely make things worse. It's the chronic workplace stress that gets to people, and so basically making it a toxic workplace can absolutely have a detrimental effect on your coworkers. So
Oh, totally.
one of the issues, is the dark humor is we've kind of relied on that for a long time, and that everybody's and we're essentially taught that dark humor is fine, it's great, rely on it, and it's gotten to the point that it's become a toxic method of coping,
Mm-hmm.
and ends up going too far way
Yeah.
too often,
And we'll
and
mention
kind of
that
catering it to
yeah,
it.
the dark humor later. It kind of comes up as one of the coping skills, and it's not nearly as high on the list of good coping skills as you might think. So this is another study that came out of a journal of psychiatry in Canada. So this is a Canadian study, and what they did was they looked at 6 categories of public safety personnel, or PSP. And they looked at correctional officers, dispatchers of the 911 system, call operators, firefighters, medics, police. And it was an online survey that lasted from September to January and back in 2016-17. And they made it available through social media. So it spread all over as well. They had 5,813 completed surveys. Okay, that's a lot. That's a good power. And the differences between sexes was only seen in police and firefighters. And so we're going to leave that data out. We're talking about EMS here. Older people, older providers were more likely to report symptoms. Single providers, or those that were separated, divorced, widowed, were more likely to report symptoms. And these are symptoms of like mental health disorder, okay? Fewer years of education, you're more likely. There was no difference between ethnicity or urban versus rural agencies. Okay, so your big risk factors, and this one with that, if you're older, you're more likely, single, separated, divorced, and fewer years of education. And so we've highlighted here the data that reports on firefighters and paramedics, because that's what our audience is. So we're not teaching to the police here. And so what you see on the left is things like PTSD, depression, anxiety, panic, and alcohol use. And then the rate of respondents who were positive for that. And so, I mean, just look at the paramedic line. You've got some pretty high numbers there, 22% for PTSD. I mean, across the board, they're fairly high, but paramedics is one of the higher ones, okay? And then we look at the next one, which is any positive screen for any mental disorder. Okay, look at the paramedic number there, and I mean that's high, and all of these are high, and so you kind of look at it and go, well, how does it really compare to the general population? This is a lot higher than the general population for all of these, but paramedics is obviously too high. Go
And
ahead.
really quick, everybody in Canada is referred to as a paramedic. So that's all levels of EMS provider when they mention paramedic.
Oh, that's cool. I was not aware of that. Look what you taught me tonight. So their conclusion is that over 40% of public safety personnel in general screen positive for significant symptoms consistent with one or more mental health disorders, compared with 10% of the general population. 4 times the risk, okay? And the higher risk was seen in older, more years of service, and those who were single, widowed, divorced, okay? So, and that just points to your social support system. Do you have somebody to go home to and complain and talk about your cases in your day and what frustrates you and kind of open up? Well, then think about working with your crew. If these data support that because you're married or have a partner or somebody to talk to when you go home, that's a more healthy and protective thing, then why in the hell would you think that talking to your fellow providers on shift isn't healthy? I mean, it's ridiculous. When is suicide in EMS most likely? The average age of suicide in EMS, approximately 40 years old, and this is from Code Green. That's an interesting statistic because that's not young and that's not old.
It is right dab smack in the middle of the average. You think about your average first responder age range is 20 to 60,
Mm-hmm.
really. I believe the youngest suicide we have demographic information for the vast majority of suicides that we track, and I believe the youngest suicide that we have on record was a 16 or 17-year-old explorer, and the oldest that we have on record is a 72-year-old chief.
And by
So,
explorer, you mean like
um,
a high school kid following along to see if they want to do it?
Explorers is a program through the Boy Scouts of America, where they are actually full-fledged. They full-fledged responders work on the rigs. They're a limited role where they for sort of like for fire explorers, like they're not allowed to go into the burning buildings, but they do like ride on the fire trucks, assist on the scenes. EMS explorers, it's the same thing. They work as like emergency medical responders where they can't do a ton of skills, but they help out with like vital signs and history taking and assessment stuff, but
Mm-hmm.
they can't necessarily perform any medical skills. So they're engaged, but don't have a whole lot of independent responsibility.
Well, let's take a short break. Let's move right along. Let's go into suicide thoughts, planning, and attempts in the data that's out there to talk about this. Look down at the bottom. This data is out of February 2018. Came out of the same data from the last survey. So basically what they did in the Canadian study is they collected all this data and then rehashed through it and pulled out some more data they could use in this study. So same survey, and those that responded about suicide, so the number who responded on this particular sample was 5,148. And what they were asking about was their reported past year and entire lifetime of suicidal ideation, planning, and attempts. So what they're going for here, and some of you might have already been asking this, is okay, yeah, we're talking about suicide, but what if these people were already depressed and suicidal before they even became EMS providers? And so this is what they're looking at here. They're separating past year and lifetime. And so it relates a little bit more to what they're doing currently then, obviously. So what they found in the results, women were more likely to report suicidal ideation, plan, or attempts. Again, higher risk if single, separated, widowed, divorced. They're more likely to report. Younger were associated with more reported past year ideation and planning of suicide. And the data suggests that thoughts of suicide may not be changing with experience, but a reaction to those thoughts is. And so, do older people have better coping mechanisms? I don't know. We have some information later on coping mechanisms, and it may just be related to life experience and your home situation and your social support or family situation. So, looking further into this, they compared to the general population. Lifetime suicidal ideation or plan for public safety personnel was over 2 times that of the general population. Attempts for police and firefighters was not statistically different compared to the general population, but attempts for correctional officers, their EMS providers, and call center operators was significantly higher. And you'll see there that their EMS providers, and as Anne said, this is first responder to paramedics, was nearly 10%. And that's so 1 in 10 people. So if your agency has 10 people, there's a chance that one of them, the likelihood that one of them is having some trouble is there in the data. So please, even if you have a small crew, be very careful about how you respond and talk about this stuff in front of your crew, because even if you think that it can't be possible where you are, again, there's no difference between urban and rural, size of the department. It's pervasive.
So another quick note on the difference between the United States and Canada is that in Canada, fire and EMS is almost totally separate. Some firefighters have basic cross training, but you don't have mixed departments like you do here in the United States. Like you don't have fire departments that transport patients in Canada. It's almost completely unheard of.
So you don't
So
have a
that's
fire medic in Canada, really?
no, like I mean there are some agencies where that happens. It's not set up like it is here.
Yeah.
So that's why there's that separation, why they have that delineated and why they suspect that there's such a big difference in the rates is it seems to be the EMS calls that affect people more so than the fire calls and the
Well,
actual delivery of patient care.
Yeah, and I mean, that would make sense to me just simply because as the EMS provider, you're then doing the patient care, and if you make a mistake or the patient has a bad outcome, you're going to be the one really left thinking, did I screw up or did I lose this patient? And probably the one having to talk to the family. So I can see that the stress of medical care is going to be far more than, at least in Canada, on the medic side, on the EMS side. So, what are some things you can look for in your department, in your colleagues, in your friends in EMS that might be signals of impending doom or things aren't going so well? Sudden changes in mood, if you're becoming a little bit angry or easier, or too withdrawn, kind of quiet, not really interested in participating in events anymore, or hanging out with your friends. If you start showing up late or missing work, increased comments about stress, whether it's work, family, money, anything. It doesn't have to be about the job. Increased use of substances, maybe having a bit more to drink when you go out with the buddies. Okay, if your buddies are noticing, wow, he kind of actually gets drunk now when we go out for beer instead of just having a beer. If you start making end of life plans, that's kind of a big red flag, right? If you start giving away things, a lack of interest in planning for the future. And you don't have to have all of these. It may just be one. Okay, I test positive for the top one pretty much every time I have to do a string of night shifts. Okay, my wife acknowledges that I get a little more tense, a little short fuse. I get frustrated with the kids a little easier. That's just something I now recognize, and my wife recognizes. That's like kind of goes along with the job, and it definitely is a little factor of burnout. You got to watch out for that. But the wonderful thing is, I can recognize that having a spouse that understands my work, that I can come home to and talk about those hard cases, talk about the shifts, talk about the stuff that's driving me nuts and really making me angry, or something I feel like maybe I screwed up on, or if a patient died, I can talk about the case with her. That is absolutely critical in regards to stress management. And they hit on it multiple times in those other studies that if you have a good social support, if you have a spouse, a partner, a friend, a colleague, whatever, anybody you can reliably talk to when you're having those rough days, that is very, very protective. And so I would highly encourage you to seek that out. If you don't have somebody at home you can go to, make it somebody at work, somebody you trust, a buddy at work that you're like, dude, can we just like once a week just hang out, have a coffee, have a beer, whatever, and just talk about our weeks, because I gotta get this stuff off my chest. I feel like I'm questioning my care. I'm not sure if I'm doing the right thing. And just having that social support, somebody to talk to, will save you so much trouble, a ton of trouble. Looking at substance abuse, this is something that is a pervasive problem, and it goes along a little bit with the environment. I mean, like we talked about, you had a young population in this culture. They're kind of gung ho. It's a high intensity, high stress environment, and with that comes work hard, play hard, right?
Yeah, it's one of those things that I think pretty much everybody listening to this has heard on multiple heard slash said. It's been a long shift. I earned this, or I had X number of calls. I earned this, or I deserve this, or what, some variation of that phrasing.
And that's a
Um,
dangerous phrase to say, because what happens when the stress gets more and more?
Right, exactly. And then just to kind of probably ruin at least a few people's days in here. So the definition of binge drinking, it is for females, it is 4 or more drinks in 2 hours. Males, it is 5 or more drinks in 2 hours. And a drink is defined as 1.5 ounces of hard alcohol, six, I think 6 ounces of wine or 8 ounces of wine, and then 12 ounces of your standard like 5 ABV
Hmm.
um, beer. So,
And from my
you know,
limited drinking experience, I know
drink.
that 1.5 ounces is a shot.
Yeah, yes, a shot. This is your standard. So, something like 2 Long Island iced teas in 2 hours. Congratulations, that's binge drinking. A regular sized bottle of wine for a woman, a full size regular sized bottle of wine in 2 hours. binge drinking. Yeah.
That is eye-opening, but luckily, I think I'm well under the category at this point, being kind of old, gray-haired, and having little kids. I don't hit it that hard.
So now I will also add that there are some the definition of binge drinking does not take age or height or body habitus into account, and so there are some criticisms with that that have been brought up there. But so
Throw another piece of data out there. For those of you who think that your tolerance to alcohol is better than other people's, you're actually incorrect. It has nothing to do with body size, male, female. What's really fascinating, there's a doctor that he's an ER physician, and he actually did a study on alcohol. I mean, it was talk about a fun study. He had a bunch of people drink alcohol, but he looked at the whole. I can tolerate alcohol better than my buddies, or like I'm a better drunk, or it takes me longer to get drunk. And it had nothing to do with sex or body size. It had to do with hydration. That's really what it comes down to.
one of the other interesting things too about alcohol tolerance, and this actually applies to all drugs, is location. Is if you're drinking or using any drugs in a location you're familiar with, you will tolerate it better than if you're in an unfamiliar location. Yeah, it's a weird psychology compensation thing.
And so we don't forget to mention here that 99% of the people that screen positive for PTSD admitted to binge drinking in the last 3 months, which
Yes.
is pretty telltale then of things are going badly, is if they start drinking more and abusing substances. And obviously, they could be abusing anything, but just alcohol is so readily available. It's easy, it's legal, and so it's there.
Yes.
I mean, these providers may be abusing narcotics, but it's much harder to obtain or hide, for that matter, when you're sleeping.
Yes. And because alcohol is already part of the culture, it is very, very easy to just hand wave it off and kind of get people to not worry about it.
One quick mention on heart disease. This is just about keeping you healthy, because the more unhealthy you get, the more likely you are for higher stress, decreased job performance, and the more stress that comes along with that. But EMS providers are at one of the top people on the list career-wise of professions with the highest incidence of heart disease. And it's related to stress, poor sleep, and their fast food eating habits. And you see the ambulances parked outside Burger King there. It's not easy when you're on the job and your ambulance is parked or stationed somewhere, and most of these places you're going to park in a parking lot. And so your access to Starbucks and Burger King and McDonald's is really, really easy. So be very careful of that. The fatality rate for EMS, this is in regards to ambulance crashes, as you can see in the background there, but 12.7 per 100,000 people versus the general population, 5 per 100,000. That's a big difference, and this is obviously linked to driving a little bit more dangerously. You're at higher speeds.
Wear your seatbelts.
Well, yeah, and there's the other thing. So, Anne, when you're in the back of the rig, obviously we don't recommend transporting CPR in progress. But let's say you're just doing general patient care. What would you say? Do you think a lot of people in EMS are doing general patient care with no seatbelt on? I mean, I've seen the new rigs that are out there where the seat can move about the patient so you can stay buckled in. But like the old rigs, if you want to do any patient care, bend over the patient, you're unbuckled.
I'm short enough that with the older style rigs that if I was buckled in, I couldn't put my feet on the floor. Feel free to laugh. That's
I just
fine.
had an image of like a little short Smurf there. Sorry.
Yeah, no, that's pretty much it. So yeah, it was my option was either be buckled in and like not be able to actually reach the patient like little hamster pawing at the air, or be able or not be buckled in and actually be able to do patient care. So they're getting better about it with the newer ambulance designs. I mean, those are major issues, and we're kind of getting a little bit off into left field, but frankly, this all kind of ties in together, because talk to somebody who's lost their partner in an ambulance crash and you'll start wearing your seatbelt real fast.
Yeah, well, I can tell you right now.
That's not something you want to live through.
Yeah. In doing this talk, you can find, if you go Google, after this talk, please be my guest, go Google like ambulance photos and type in like cool ambulance or fast ambulance, something neat, and you'll get some photos of ambulances, kind of neat Photoshop photos. Go type in ambulance crash and see the difference in how many available photos there are. It is frightening. And you talk about a lot of crashes out there that the general population really doesn't hear about. This stuff happens a lot.
And ambulance boxes are made out of aluminum.
Aluminum tends to bend pretty easy. Crush easy, right?
Yeah, they're not crash test rated.
uh, so let's talk about burnout. This is something that all of us in this profession of emergency medicine, emergency management, EMS, anything emergency, will likely experience at some point, whether it's after one case or many years of repeated cases. Okay, this is something I felt. I still feel sometimes now. Everybody has felt it. Okay, working with sick and critical patients. Burnout is it's kind of a theme. It's not something you're really going to have a lot of symptoms of. You start to have different things that happen, and for everybody, it's a little different. It can include any one of these or multiple of these. You might have increased feelings of emotional exhaustion where you just feel exhausted physically, emotionally. You don't feel like working out. You don't feel like doing anything. You can have negative attitudes towards patients. Okay, and that happens in all of us after a period of time, depending on the patient population you're working with or their complaints. You could start to have negative self-evaluations about work where you start to question the way you're doing things and if you're being a good provider, if you're staying up on your education, if you're doing procedures right. You're starting to feel dissatisfied with your accomplishments on the job, where you start to kind of poo-poo the good job you're doing and the good work you're doing, okay, and what people think of you. You feel like nobody cares what I'm doing, nobody's appreciative of what I'm doing, and you're kind of not recognizing when they are. And this basically comes from sacrificing yourself to meet unrealistic work demands. And so you start putting a lot of pressure on yourself to be Superman when you're not Superman or Superwoman.
Yeah.
And so it's putting those big demands on yourself.
Yeah. Additionally, not being recognized, feeling that you're being unrecognized or undervalued.
Mm-hmm.
So even if you're not having unrealistic work demands placed on you, just feeling that nobody's valuing you for what you are doing.
You never hear a "Hey, good job" or "a good case" or "You did good care," or "Hey, I appreciate what you're doing today." You're not going to hear that a whole lot.
Right, exactly. And EMS, fire EMS, is really kind of ripe for this, because if you think about, a lot of us work in kind of the environment where we don't necessarily have fixed stations. So you go into work, you pick up your ambulance, you go out on the street, you stay on the street for X number of hours, and you may go 12 hours without ever actually like seeing your boss. You may like hear him on the radio or talk to him on the phone, but you don't actually see them. And so the only time you end up actually like communicating with your boss is when you do something wrong, or or need something. And so you don't get that the little feedback that, hey, like, good job on cleaning your ambulance or whatever. And yeah, it seems kind of like silly and petty, but humans need validation. It's just one of those things that we kind of thrive on. And when we don't get it, like, we end up getting burned out. And this is one of those things that like, you can help your partner out with. This is just little stuff, like, you notice that your partner is like taking out the trash in the ambulance every day this week. Is like, just mention that, and that sort of stuff can like really kind of bolster somebody's confidence and help them out a lot.
And it's funny, you don't need to go buy somebody flowers or a present or anything. It's purely just a simple thank you. It does amazing things.
Yeah.
Yeah.
It doesn't necessarily take a lot. Is just, the little tiny stuff like that can go a long way.
This is interesting. The burnout personality, people who are more prone to burnout. If you read through these, this is people that go into fire and EMS.
The Venn diagram,
yeah,
is one big circle.
Yeah, I mean, this is our profession. This is what we do. This is us. We thrive on the intensity of it. We set ourselves up from crisis to crisis. We love that feeling. We function pretty well under pressure. Okay. I mean, this is you, this is me, and this is the people who are more prone to burnout. So enough said, right? The unexpected, okay? So the trouble happens when your mantra of like, I'm a lifesaver turns into, shit, I did everything right and somebody died. Or worse, I think I did something wrong and somebody died. That's that will end up being a big problem for you. And even if it's one case, it's something that's going to stick with you for years. And then let me make it worse. Let's say that after this case, you get a letter maybe a year or two later that you're being sued because of what you might have done or didn't do with a patient. Even if you weren't wrong in doing it, this is coming from personal experience of having colleagues that have been sued for a patient case, even if they did nothing wrong. They did good care. I mean, good care, but people sue for the dumbest shit out there. They want a paycheck, or maybe something did go wrong. Maybe you did screw up. But when you get sued for something, you talk about ruining a career. I've seen ER doctors, I've seen other physicians, their first and only lawsuit was a career ender, even though they did nothing wrong. It's because in trying to fight it or going through it, the depositions where you have the other lawyer questioning you about your care, they're trying to rip you apart and make you sound like you are an uncaring, uncompassionate, horribly trained idiot who shouldn't be doing this job. And that is a career killer. And so this is a high stress environment. And for somebody at the age of 19 to be doing this job with no experience otherwise is a very high risk scenario for something like this. Yeah, nothing like having somebody accuse you of being a bad provider. That'll kill you. And then we have this. This is going to lead to a lot of burnout. And this affects me a lot. And I can imagine it affects you, the EMS providers, a lot more. Okay. Overuse of the 911 system. This has become ridiculous over the last 2 decades. This is a major contributor to burnout, both on your side and my side in the ER, both with nurses and physicians. It just drives us nuts. It affects the views we have of our patients and general patient populations. We start stereotyping certain populations of patients, whether it's the homeless, the drug addicts, the people who are addicted to narcotics after surgeries. We start formulating these stereotypes in our head, so when the next patient comes in, we just stamp that patient, just put a big stamp on their forehead of you're this stereotype, and it will affect our treatment and our management of how we deal with these patients. And this is going to lead to all sorts of problems. I mean, it's going to start now. It's going to happen more in the future. We're going to be missing diagnoses. I see it at least once a month where a patient comes in and everybody assumed in the field that they're just a drunk, and they come in and yeah, they look a little intoxicated, they're confused, and then I do a blood alcohol level and it's 0. And then you go looking for other problems and you find a little head bleed from the fall they had yesterday. And we're doing this over and over and over, and we're just becoming jaded. I mean, you guys, me, we're all becoming pretty jaded because of these patient populations who are abusing the ambulance. And so shame on them for doing it. How do we stop it? Pretty darn hard to do. There are some situations like urban settings where they're allowing the EMS providers, they're giving them protocols to evaluate the patient in the field and monitor them for a short period of time, and then to deny them transport and to recommend they call a taxi if it's non-emergent. In places like Spokane and Washington, that's not possible. Our protocols are basically you call 911, you're getting a ride. And so it's a part of the system. It's something that's going to be really hard to fight. The main thing we can do is to try to keep a better outlook of our patients and populations and try not to let it affect us more, and just realize I'm on shift from this time to this time. I'm going to have these cases happen. I need to be ready for them, know it's going to happen. I can't stop it. And just kind of be a little more objective and not so subjectively putting your emotions into it. What would you say on this, Anne? I mean, you're exposed to this more than I am.
My approach was basically just making sure that I was consistent in my assessments, and that doing the same amount of assessment every time, even if I was like personally felt one way or another about the patient, just because of that risk, and knowing that eventually, like, I didn't want to be bit in the butt and run that risk. It was like, well, statistically, the likelihood of me getting bit in the butt is higher. So I'm going to make sure that I'm still going to do a thorough job. And I'm still going to have the same amount of paperwork no matter what. So
yeah, documentation, that's another stress, right?
right. Yeah, I'm still going to have the same amount of paperwork at the end of the day. So I'd much rather spend the time doing doing a full assessment now, and and then risk having to explain later why I made some bad assumptions and missed something that I really shouldn't have because I prejudged my patient.
And that's a lawsuit you can't win. I mean, that's one where you
No,
don't even fight it when you realize
no.
that you misjudged something and didn't manage it like you would anybody else because of what you stereotyped them as. That's one where you just tell the lawyer, yeah, I screwed up. We're gonna have to want to settle this one.
Oh, and then so many of those patients that we do tend to stereotype too are at high risk for so many things anyways, that you think about the patient who is the alcoholic that we've seen how many ever times. Well, what does alcoholism make them at high risk for? Brain bleeds and GI bleeds and MIs. And so, well, I don't want to be the provider that misses the when they do finally have the actual GI bleed that they're eventually going to have because they're because of their 3,000 comorbid conditions.
Yeah. Provider fatigue. This is something that's obviously going to be out there, especially with the nights and weekend type work and decreased sleep. And sleep deprivation's been well studied in the past. There's literature out there from like the CDC and the National Sleep Foundation. And of course, they recommend 7 to 9 hours of sleep over 24 hours, which consistently is laughable to me as a working father of 2 little kids, and you kind of just say, that's very nice of them to suggest. Thank you very much, but it's not going to happen very often. But then you look at the EMS survey reports, and 50% of EMS providers reported 6 hours of sleep, and 70% of EMS reported problems with sleep. And so it's obviously going to be an issue anytime you have shift work, night work, providers who are maybe doing EMS and another job, or EMS and still in school for other things, and it's going to destroy your sleep, and that's going to lead to sleep deprivation, which is a torture technique. Okay, so sleep deprivation, it's used to torture people, so obviously it's bad. Moving on to a study out of 2017, June GEMS. So what they did here was they did an article on a study that had already been done regarding mitigation strategies to decrease provider fatigue. And what it basically was talking about before they got into the mitigation strategies to avoid EMS provider fatigue was they talked about how many cases of EMS crashes are out there from people falling asleep at the wheel. One EMT was criminally charged in the death of a patient they were transporting after they had fallen asleep at the wheel while driving an ambulance and ran into a tree, and the patient died there. And then there's many other cases of EMS crashes that were suspected due to fatigue or falling asleep at the wheel. And so we'll talk about those mitigation strategies in a little bit, but we want to move on to workload. What is the classic workload of an EMS provider? Well, obviously you have your shift length, whether you're having back-to-back calls, and are they going to allow you to get your documentation done in between those calls? Maybe, maybe not. Physical fatigue, I mean, you guys are lifting patients in the field, getting back injuries. The mental fatigue of doing the actual patient care, that mental fatigue I've noticed for me in dealing with patients, it's really amazing. Like, I can sit down for most of my shift. I walk from room to room. I don't do nearly as much physical labor as you guys do in any way, shape, or form. And at the end of the shift, I just feel so drained because of the mental fatigue of like thinking about patient care and trying to think about all the differentials and how to manage each case individually and do all the right stuff. It is draining. So I can't imagine doing that plus of all the physical stuff you guys are doing. It's impressive. Hats off to you. And then you obviously have the emotional fatigue that comes into play with those bad cases and critical stress. And then documentation is one big pain in the butt, right? And then, so I had a bright idea recently. I said, what we need to do is I need to come up with some scientific thing to pass on to you all. And so I came up with my Dr. Dierks job suckiness graph. And this is my interpretation, by no means scientific. Okay, I'm not quoting anybody here. This is just me having fun. So here is what I figured is doable. If you only work a shift that's a few hours, high workload, that's tolerable. You can do that. I could have a major workload, horribly fatiguing, if it's only a shift that lasts 1 or 2 hours, right? You could do that. Or you could work a shift that's many hours, but just a little bit of workload, and you could do that. So this is happy. I could do this. That's a good career. But if you're anywhere in this range, not good. This is going to lead to job suckiness. And this is not good. And here, this black line is what I call your suckiness demarcation line, or SDL, if you would like to quote me. Now, if you're factoring in extra jobs, parenting, anything that makes anything harder, your job suckiness, your SDL, your suckiness demarcation line, is going to move drastically to the left. And it's going to make shifts a lot harder to work. And so think about this in relation to your life and all those influences you have outside of work, the stresses outside of work or in work, and what that's going to do to your ability to cope with stress and shift work. And your ability is going to be different than your partner's. Everybody's graph is going to be different. And so your SDL may look different than mine or somebody else's. You probably don't want to quote me on any of that because none of that was scientifically proven, by the way. Now, this is science. Signs of depression. In med school, we were taught SIGE caps, and you see it there, SIGE caps. And it's a way to remember some of the symptoms of depression or signs of depression that you can see in people. Sleep changes, loss of interest in like your usual activities or hobbies, feeling guilt or worthlessness, a loss of energy or just feeling fatigued, and that can be mentally or physically. C is cognition or concentration, just trouble concentrating. You find yourself having to read the same paragraph in a novel twice or 3 times because you're just not paying attention to things anymore, or not paying attention when your significant other at home is talking to you, although that might just be a whole other issue we need to address later. Appetite loss or weight gain. I would say weight gain, weight loss, both. Psychomotor agitation, that doesn't mean that you're like having seizures. It just means that you're getting a little bit restless or anger a little easier and just feel like you need to move around a bit. And then obviously suicidal. Symptoms of anxiety, this is stuff that we see, but we just got to mention it. So when people feel nervous, restless, edgy, short fuse, that can be anxiety. They don't have to be tachycardic. They don't have to have any vital sign changes. It could just be symptom only. This can happen before shifts. This is something I've experienced before. I don't have generalized anxiety disorder or anything, but I recognize that there's been times in my life or my career where before a string of shifts, I'll get a little more edgy or short fused, and I recognize that that's a factor of burnout. And then luckily, because of doing this stuff and education and talking with EMS providers, I can recognize that stuff and then take care of it. But for those people out there that might not recognize this is what's happening, maybe your colleagues are recognizing it. And this is where we need to talk to each other and kind of call people out and say, you need any help? You need to talk about stuff. So if you see this in your partners, just don't be afraid to address it, okay? You might avoid a disaster. And then obviously we've already talked about substance abuse and if it's a cultural problem, if people are abusing it as a sleep aid, that's really never good. Okay, if you feel like you need to have a few drinks before you go to bed to get better sleep, that's a bad thing. Okay, you probably don't want to be doing that. Post-traumatic stress disorder. Now, Anne, you have better data on this than I do, but PTSD, what can you tell me in regards to the rates of PTSD like in the EMS population compared to that of like military? I know I've talked with you before about that, but what's really out there?
So the best data that we have for the rates of PTSD in first responders indicate that it's roughly on par with active duty military. So for a diagnosis of PTSD, you have to have meet a certain number of criteria in each of these categories. And so when we talk about PTSD, we talk about people who have what they call full PTSD or partial PTSD. And it's estimated anywhere from about 15 to 25% of first responders meet the diagnostic criteria for full PTSD at any given point in time. The majority of those actually overcome those symptoms on their own without having long-term severe issues. An additional 10 to 20%, it varies a lot depending on the study, have partial PTSD, which is where they have some of these criteria but don't necessarily meet the full diagnostic criteria at any given point in time. So we're looking at somewhere from 30 to 50% of the entire workforce, depending on which data you're looking at. It's a lot.
And it would make sense just from the EMS career of being exposed to multiple critical stress environments or situations throughout your career. And it can be one situation or multiple. And so the chance of developing PTSD similar to that of the military, it makes sense.
Yeah, and some of it, and some of the reasons that it's so high are the fact that we are really bad at handling our emotions, and it goes back to kind of what we talked about. And this, of course, sounds like I'm picking on guys here, but it's a male-dominated profession. There's already guys are not always the best about talking about their emotions. And so, you take a male-dominated profession that's already got a lot of substance abuse issues. And so there's already kind of all these almost predisposed factors that kind of mesh with the PTSD symptoms. So we're already kind of halfway there for a lot of people. So it doesn't necessarily take a lot to, doesn't take a major incident on top of kind of our basically the cultural predisposition that exists.
We should stop talking about this. It's making me uncomfortable.
And like I said, though, is that for the vast majority of people, it's not that we are all it's not that 50% of the profession is walking around needing inpatient therapy all at once. So it's not anything to that extreme.
And I was joking, obviously. Just want to clarify that for everybody listening. So what is a normal response to some of the stress we go through in our careers? Okay, it's totally normal to feel angry, to feel grief-stricken, to feel kind of, quote, depressed or sad about a case or cases you've seen after a major event. Okay, and it can be one event. I can still remember everything about my shift, or at least the case where I had to hold the little kid who's peeing his pants because his mom was beating the crap out of him. I remember everything about it, but it was one case that lasted just a few hours. That was it, one case. And that's the major case I remember after a career of 10 years so far. I mean, I can remember gunshot wounds and stab wounds and people dying left and right. I can remember lots of that stuff, but it doesn't bug me. That was part of the job. I was okay with it. I did good care. I felt confident in it. But the one case that still bugs me to this day, there was nothing medical. There's nothing I had to do, but it still bugs me. And so it's a normal reaction to feel all these emotions after a major event. But if it's becoming more than that, if it's affecting your sleep, if it's affecting your relationships, if it's affecting how you treat people, you need to get some help. Okay, you need to I'm going to put this out. You need to man up. Okay, if you're a female, you need to female up. And acknowledge it. It doesn't mean you have to go tell all your whole crew if you're uncomfortable with that, but by all means, go to the person or somebody in your workplace that you feel like would point you in the right direction, or contact one of the resources we'll have at the end. And you don't even have to talk about it with your crew, but I'm telling you, don't suppress it. It's going to be a big freaking problem down the road if you try to suppress this stuff, okay? And this is what you'll become. Okay, there's another, Paul Combs is just fantastic, the stuff he has out there, and he's got a lot of the stuff. I recommend you go and look at all of his stuff. But there's no shame in admitting you're human. Okay, and the guys that are out there saying, I'm fine, I'm not going to get burnout, those are the guys you got to watch out for, okay? So some of the factors that will increase your risk. Having multiple events over time makes sense, just the more exposure to it. The level of involvement, if you are the person doing the direct patient care, puts you more at risk. Feeling ineffective in your job, not processing your emotions very well and suppressing them, that's going to set you up like a ticking time bomb. Obviously, using substances to cope is never a good idea. And then if there's any personal stress outside of your job, whether it's home, your other job, your marriage, your kids, financial stuff, any of those other stresses, obviously they're going to weigh very heavily on your mind and your job effectiveness and therefore then lead to other problems. And you become a setup for disaster. We've already acknowledged that it's historically been a culture in fire and EMS, a bit machismo. There's a lot of dudes in it. And dudes can't be weak, right? We can't cry. Oh, God, no, you can't cry. You can't feel sad. And you sure as hell don't ever talk to your male colleagues about how sad you are. That's bad, right? The emphasis has always been on bravery and strength and dealing with anything. I mean, Anne, what are your thoughts?
We actually have a study that was done.
More studies. Jeez, you got all this
studies.
data.
We have a ton of studies and data. This is one that always entertains me to bust out. It was done in about 250 firefighters. That I cannot quote the full title verbatim off the top of my head, but it was there was a correlation between being scared of their emotions and PTSD symptoms. Like in the title of the study, scared of their emotions. There's some issues.
So what you're saying is if people are afraid of their emotions or afraid to let them out, they're more likely to develop PTSD?
Yep. That was
Ooh.
they actually could not they couldn't there was a chicken and the egg in the conclusion of the study. They couldn't, draw any conclusions about what came first.
Sure.
But there was a correlation, is that the firefighters in the study that had more symptoms of PTSD were more scared of their own emotions and of other people, of hearing about other people's emotions. So
that's like a whole new talk. Oh my gosh. And one I'm going to avoid, man. I don't talk about my emotions.
250 firefighters is not a small sample size for this stuff. So I mean, it's difficult, but yeah, it's one of those things that if you can make yourself talk about this, you will be better off.
So let's move on to your actual mental health. Okay, let's kind of go through some of this stuff. Sorry, I hope the kids are in bed and they're not reading the screen. My apologies. Don't let them see the screen right now. But I'll let you read this. I'm not going to read it out loud, so it's not broadcasting through your home. All right, so there's a problem with this thinking, obviously. Okay, it's going to lead to some big issues, and you're going to affect others. So getting stronger, think about this, okay? We always feel like, oh man, I need to work out more. I need to walk on the treadmill. I need to lose some weight. I need to get healthier. But nobody ever really talks about working out their brain or making their brain healthier. And it's just like another organ in your body that you need to keep healthy. And so we should strive to take care of our physical health. So then why do we think differently about our mental health? And this is something I had a problem with. Like, I've always been that machismo kind of culture of, working with the surgeons and working in a kind of a male-dominated culture of this high-energy emergency medicine stuff. And nobody ever really talks about your mental health. It's always this kind of negative buzzword, mental health. That person's got mental health problems. And so we have created this big negative image around it. And it's taken me a long time to really grasp the concept, but now I totally get it that if we don't exercise our freaking brains, if we don't keep them healthy, they will get mushy and bad, okay? Like an atrophied muscle, they're just not going to be as strong as they should be. And in your career, you need to exercise your brain. All right, this career is not meant to be a temporary, short-term thing. This is meant to be a job that you can do for years. And I'm going through this in my own career of like, I'm an emergency physician. I got in this to do this until I retire. And so I need to get over these stereotypes and the stuff that bugs me or burns me out, and I need to move past it and become something better. And that's part of that mental health growth. And protecting yourself will then thereby lead to better job satisfaction, improved mental health, improved relationships, career longevity. It just leads to all good things. Now, hopefully everybody's out there kind of reading on the side just for their own enjoyment. This is a book I read recently about it's called The Happiness Equation by Neil. I don't know how you say the last name. Sricha. It's a cool name. But this book is outstanding, and I think all people in emergency medicine and EMS should read this book because we are prone to need this type of stuff. And it's I don't know, I guess you would say it's a self-help book, but it's not like, oh, you should feel better about yourself. It's not all this cushy stuff. Here's one of the things in it. And this is something I was wrong on. I agreed that if you have great work, you'll be a big success, and that will lead to happiness. And that's what people have been teaching for centuries, right? This is like right out of the 1930s. You work hard, you do good work, you have the American dream, and then you're happy. And what this book really goes through, and it goes through much, much more, as it says, this is really bullshit, okay? What the reality is, if you're happy, you will then do better work, and that will lead to bigger success and long-term career longevity, okay? You got to be happy first. You got to be happy with yourself, with your life, your relationships, what you're doing, and then that will lead to better activity, better work, okay? So great book. I recommend you all go out and read it. Just get it from the library. You don't have to go buy it. It's fine. Coping mechanisms. This is something we have to discuss in this kind of talk, okay? How you cope with stress can be healthy or unhealthy. We've already talked about drinking as an obvious unhealthy choice. And so let's talk about something that's out there. This is out of a 2012 study. It was in EMS World, and it's Are You Under Stress in EMS? And what this did was it went through some of the coping strategies reported by EMS providers, both positive and negative, and then weighted them by the percent of providers using that strategy. So on the right, it's not so much as this is the most effective, it's just that the percent of providers reporting that they use the strategy. Okay, so the positive ones, talking with colleagues, ding, ding, ding. Okay, so if you have colleagues you can't talk to, if you feel like they're really negative about this stuff, maybe move on to number 2. Okay, thinking about positive benefits at work. If that doesn't work for you, focus on your outside interests. This is something that's really big to me. If you like to, what were you going to say?
I say have outside interests.
Yes, find something you can do.
Cultivate outside interests.
If you don't have any, go pick up a book about hobbies and pick a few that you might find interesting. But find something you're interested in, passionate in, that's not work related. I mean, what I'm not saying here is don't then pick like to do a research study about EMS patients. Don't do that. Pick something that's completely unrelated to your job. If you like gardening, if you like working with your dog, if you like hunting, whatever it is, focus more on that. Focus, like, look forward to your free time, and you see it down there further. Look forward to off-duty time. Thinking about your own family or being with your own family. If you're divorced and don't like your spouse anymore, then maybe move on to a different one. And you see their black or dark humor. It's listed. It's pretty common still. That can be good or bad. You can read through these, the goods, the bads. You obviously can see the bads, and those make sense as well. But number 1, that's bad. Keeping your thoughts or feelings to yourself. Obviously not good. Okay, rely on those relationships that you have. Now, stress and dying, these are obviously part of our work, something we do. Really, the response to this, you need to be able to talk to somebody following it. Whoever that is, it doesn't matter. Obviously, if you're talking to friends outside of work, or even in work, you just got to be careful about HIPAA. But you can completely talk about your stress in your day and you had a bad case. You don't have to give specific details. You don't have to say who it was or where it was. Don't do that. That's breaking the law. But totally communicate about this stuff. Talk about your days and your stressful encounters. It's what you need to do, okay? And the best people to do it with are people that understand what you do, and that's your colleagues. Okay, those are your colleagues. So what I recommend is in every department, okay, for those of you out there who listen to this stuff, what I recommend in your department is maybe you set up a time. You guys usually have like monthly meetings. Even the rural places, you usually have a monthly meeting. I recommend you set apart like 10 minutes at the end or beginning, wherever it is, just to do a quick check. If you're the chief or you're the EMS officer, be the leader and just say, every month we're going to start doing a check, and I'm going to say, hey, how's everybody doing? And that's your time to air issues. Get it out there, say it's not on the record, this is private, and just open up the floor for people to kind of unload. And you might be surprised at what happens. Okay, you might have a lot happier people on your crew and maybe less turnover. Okay, turnover is spendy. Moving on to most common coping mechanisms for caregivers. These are some of the most common that are good. Sense of competence, that's always great, right? Sense of control, hard to do in our profession. And sense of a pleasure in one's work. So these sometimes can be hard depending on your shift. And the more feeling that you have of belonging to a team, the better off you are. And so getting back to that article from the recent GEMS, what they did was they were talking about this information that came out of a study by Patterson, where they reviewed the evidence out there and they found evidence-based guidelines for combating fatigue in EMS-specific providers. And this was a collaboration with the University of Pennsylvania and, their Department of Emergency Medicine, and then the National Association of EMS Officers, okay? And what they did was they reviewed over 38,000 articles that were already out there, and then they reached a consensus on 5 areas. And this is a special pay attention moment, because this is something you can pass on to your EMS officers. Recommendation number 1, agencies should institute quarterly fatigue and sleepiness surveys to measure and monitor fatigue among their personnel. They did provide some information on specific surveys, so you don't have to go create your own. They should be shift specific, so like day shift versus extended versus nights. Okay, so that's one thing. Quarterly evaluations for fatigue and sleepiness. Recommendation number 2, EMS personnel should work shifts shorter than 24 hours in duration, but they acknowledge that in some circumstances and areas or locations, the longer shifts may be necessary. So they get it, but obviously, per the Dr. Dierks suckiness graph, the longer you work, the harder it is to tolerate life and get your sleep like you need. Recommendation number 3, these are going to get real interesting. The panel recommended that EMS personnel have access to caffeine as a fatigue countermeasure. That's no joke. I actually read this and I was like, oh my gosh, that's kind of silly. But they actually backed it up. They said there's available evidence showing a positive impact on performance. I mean, not falling asleep at the wheel, for example. They did not specify the actual optimal dose, but in previously cited literature, 250 milligrams per day was cited as a low to moderate and generally safe. Okay, it's like a cup of coffee. Administrators, they said this is in quotes, administrators may need to supply stocked coolers for those crews that are kind of remote or based in places where they can't have access to coffee or a soda or whatever. What I would add here is that I recommend, avoid drinking caffeine that's just full of calories. I mean, don't sit there drinking the Coca-Cola all night. You're going to end up staying awake, but you're going to gain weight and become unhealthy. Recommendation number 4, this is great. EMS personnel should be provided with the access, opportunity, and permission to nap while on duty. Sleeping, not just resting, had a positive impact on outcomes, and they recommended for all 100% of extended and night shifts. Boom. I love that. And so then in doing this research, I found this on the internet, and it just pisses you off that people with their stupid phones and catching people doing work, like obviously, like Ann said earlier, if you were restraining somebody in public who needed to be restrained, you'd have 15 people behind you with their cell phones getting video, and it'd end up on CNN tomorrow, and you'd look like a villain. And so this moron walks by a Washington, D.C. ambulance and sees through the window and sees this paramedic dozing off at night. You can obviously see through the windshield. It's night. I mean, what a prick. I mean, come on. And so this is just ignorance, okay? Ignorance. Recommendation number 5, the last one. All EMS personnel should receive education and training on sleep health and the dangers of fatigue. So that's pretty impressive stuff. And so getting back to the bucket. Okay, so how is your bucket going to be affected? Your bucket today may be great. It may be really big and you can handle a lot of stress. a lot of stress. But then you think tomorrow, your next shift, if your spouse leaves you, your child gets a terminal illness or dies, okay, you have a major financial crisis. Whenever you go back to work, and for a long, long time, potentially forever, you will be forever changed. And your bucket will change. Your reaction to stress will change. Okay, so don't be ignorant about this. You might be mentally tough and have all sorts of support and feel like, man, I can't believe people have mental health problems doing this job. This job is great. I like this job. That's ignorance. Okay, you don't know what other people are going through. You don't know what they've been exposed to. You need to have an open mind. And if one of your providers or your colleagues comes up to you, or you hear through the grapevine that they're having trouble, man, for you to be negative about it or to be kind of bullheaded is horrible. And you could potentially make that person do something really dumb. Okay. And so kind of open your minds about this stuff. It's time to put aside the machismo and start helping patients and our providers be better. So, Anne, I'm going to let you talk about these resources. This is towards the end of the talk. We're almost done, everybody. But I'll let Anne go through these resources because she knows them better than I them. I'll just advance the slides for you.
So this is us. We do a lot of advocacy and education, travel all over, lecture at conferences, lecture at individual organizations, generally nice, warm, and fuzzy education, but occasionally be a little feisty when necessary. We publish, we actually started as a storytelling campaign, still collect stories. We actually just got approval for our first research project involving the stories, which should be going live here any day now. Do a lot of stuff on social media, talking about, ignorance and stuff on social media. That's one of the major things, is that if there's ever a social media conversation that you get involved in or you see and you don't feel comfortable dealing with it yourself, you can tag us and we will show up and deal with it. We love doing that. It's talk about unhealthy hobbies. That's ours. We help track first responder suicides. And then we also maintain a resources database of first responder oriented mental health resources, counselors, therapists, all sorts of stuff. They're all what is considered culturally competent. So they understand first responders, inpatient treatment centers, even things like helpful apps and websites, which is all linked on our website. So there's a whole host of different options when it comes to treatment. There's lay treatment options, things like, peer support groups where you're just able to talk to a peer casually, different types of formal counseling, anything from like equine assisted therapy, horse therapy, yoga therapy, formal sit down therapy with a counselor or psychologist. Medication. I know medication gets kind of a bad rap, rather ironically, since we're all healthcare providers, but if you're not in the right mindset, then the therapy won't work. And there are a lot of different options for medication that do not affect the ability to do your job. So including a lot of different options for sleep that don't involve things like Ambien that can affect your ability to do your job. So when it comes to EAPs, most major employers are required to have EAPs due to their size. And so generally speaking, employers will have a minimum of 6 therapy sessions. You may not get a therapist that specializes in first responders, but it's generally free and it's something until you can find a counselor or therapist that specializes in first responders. And it's, it's free. So there's that. And a lot of times they'll also have specialized things, financial counseling, marriage therapy, and those kind of specialized options too, in addition to trauma therapists and those kind of things that you might end up needing. So they kind of have the full spectrum of options available rather than just options like peer support. CISM, this is one of the things that is hit or miss depending on the area. It used to be a lot more popular, and then the funding kind of started to dry up. It used to be grant funded in a lot of areas, and then grants are one of those things that can be kind of fickle. So, but they're in general, you will know if your area has a CIS team available. One of the downsides with CISM is that usually it is a team that has to be activated. And so they tend to come out after large events and have a kind of a set response and have to be activated through a designated person or management. And one of the things that a lot of agencies are moving towards is having a mixed approach where they're combining their peer support and their CISM teams so everybody is cross-trained, which makes them a little bit more adaptable. And this is actually kind of the model that we recommend. It tends to work really well. With CISM, it tends to be a single session debriefing where you're able to meet with somebody that is CISM trained and talk about whatever the incident was that is affecting you. Safe Call Now is actually also local here to Dr. Dierks and I. They're also here in Spokane. They're another organization that is, they do a lot of education, and then they also run a 24/7 helpline, which is that red number you see up in the top. They are a crisis referral service. If you are in crisis and you call that number, it will be answered by somebody that is either a current or former first responder. And then they do crisis placement. So if you're a first responder that is in crisis, suicidal, threatening suicide, and need to be placed into treatment right now, that is something that they can handle. So. And then Share the Load is run through the National Volunteer Fire Council, and they also have a helpline. The people that answer that helpline are considered culturally competent. They are trained counselors that have additional education in counseling fire EMS people and assisting them. So they don't do crisis placement like Safe Call Now does, but they can talk people through crises and help them in getting connected with resources that they need for whatever is causing the crisis that they have. And then this is the National Suicide Prevention Lifeline, is the general national suicide prevention number. We've actually talked to these people a couple of times, and a surprising number of first responders volunteer for them. And so if you call this number, you actually have a fairly good chance of getting a first responder as your crisis counselor. So there's that too. So, and this is one of those, it is not a first responder specific number, but they are always an option. And then the Veterans Crisis Line is the same phone number as the National Suicide Prevention Lifeline. You just press, if you're a veteran, you just press 1 and you'll be routed to the veteran specific information line.
So if we have any questions, I'll review them now. I'm looking through this, and we don't have any specific questions about any particular topic, but we've definitely struck a chord with quite a few people in a good way. One provider said, looking back at 20 plus years, I can see why there are times I'm quiet and don't tell stories when I attend a function. There's comments like that coming in of basically people saying, this has been a quiet issue for too long. One comment was, I feel like everyone talks about kids being beaten, but there isn't much talk about young children being raped or worse. And that is definitely a true statement. We see those cases as well of rape, both in adults, teens, and younger children. And those cases are very hard to forget. You don't forget them. There's no other questions. Mainly it's all comments with people saying that they've never really spoken out and they plan to change. It's pretty good. I like it. Keep it up, everybody. Well, that is the end of our discussion. If you have any issues or questions, comments, you can always contact us, our website there, email address in the middle, or you can check us out on Facebook. We will be announcing the random winner of one of our attendees tonight on Facebook here in a little while, so check that out. And we will contact that winner and send them their $50 prize. And actually, we made time just perfect, okay? So this is a 3-hour credit, and so we're not over, so nobody get mad that we went over. So you'll get 3 hours credit for this. The test online is nice and short and sweet. I kept it short and sweet this month. But please contact us if you have any issues. If you need those resources, you'll find them on the PDF document, the quick facts document that goes with every course we have online. You just click on the link. It'll open up the PDF document. You can print that off, but all those resources are on there if you didn't write down the phone numbers and stuff. With that, I want to thank Farina for being our guest. Without her, this would have been a hard discussion for me because she has all the experience, all the information, all the data, and Code Green is a very powerful entity. I suggest everybody go check that out. And I'm going to put a plug in for it. Go donate to them, okay? You can go to their website and donate to the Code Green campaign. And thank you very much.
Thank you for having me.
All right. Good night, everybody.